Good evening, everyone, and welcome to the MSAA's live webinar, Striving Towards Better Care for the LGBTQ plus people living with MS with Dr. William Conte. I would like to take this opportunity to thank you for joining us this evening. I am Marie LeGrand, Associate Vice President of Mission Delivery, Health Equity and Education for MSAA, and your host for the program. Before turning it over to our speaker this evening, I would like to take this opportunity to go over a few of the services that MSAA provides and some housekeeping items. As you may know, MSAA is a national nonprofit organization dedicated to improving lives today through vital services and support for the entire MS community. Our services include a national helpline providing English and Spanish services Monday through Friday from 8:30 a.m. to 8 p.m. Eastern. Additionally, MSAA provides equipment and cooling products designed to improve safety and mobility and to help with heat sensitivity. We also offer an MRI access program to help cover some of the costs for individuals with MS who qualify for assistance. We provide a variety of educational programs such as this, including webinars and on-demand videos, online tools, publications, and digital resources. That also includes the Ultimate MS Treatment Guide, which is now available on our website. This interactive guide describes and compares 19 FDA-approved MS treatments and will help people living with MS make informed decisions and choices. MSAA offers support through community connection to help you stay connected with other members of the MS community. MSAA has also partnered with Talkspace, which is an online mental health service, to create an innovative pilot program for individuals with MS to receive 3 months of online therapy at no cost. Talkspace connects people to thousands of dedicated providers via secure and confidential HIPAA-compliant platform. And to learn more about this and MSAA's programs and services, please visit our website or give us a call to speak with our client services specialist, or you can also send us an email. As a quick reminder, throughout tonight's program, you will have the opportunity to ask questions by typing them into the chat box. We encourage you to submit questions throughout the program, and we'll do our very best to answer your questions during the Q&A portion of tonight's webinar. At the end of the program, we ask that you please complete a brief survey. Your feedback is extremely important and will help us in developing future programming and content. A link to the survey will also be included in the chat box. Please note that MSAA strives to provide useful, up-to-date information on matters of concern to people living with MS and their families. This program is for educational and informational purposes only and does not constitute as medical advice. For diagnosis and treatment options, you are urged to consult your physician. Please speak with your healthcare team if you have any questions or concerns. Tonight, we are going to cover several different topics that Dr. Conte will go into further detail on. Dr. Conte will provide a better understanding about living with MS and how an MS diagnosis and exploration of identity interplay with one another. During this presentation, Dr. Conte will describe differences between sexuality and gender identity and openly discuss health disparities among the LGBTQ plus community. He will also summarize how gender-affirming hormone therapy affects people living with MS and factors that influence disease-modifying therapy selection. Without further ado, I'd like to introduce our speaker. Dr. William Conte earned a Bachelor of Science degree in neurobiology from the University of Florida and graduated from medical school at Loyola University Chicago Street School of Medicine. He also completed an adult neurology residency at Loyola University Medical Center and a fellowship in multiple sclerosis and neuroimmunology at the University of Chicago. Now, while at the University of Chicago, he also earned a master's degree in public health sciences. Dr. Conte is the head of the MS Center at Methodist Hospitals and an assistant professor of neurology at Indiana University. He has a strong interest in clinical trials and research, and he is focused on providing education on how to improve outcomes for the LGBTQ plus community with MS. Welcome, Dr. Conte.
Thanks. Okay, so it's great to be here with everybody. I've given this talk a few times, mostly to doctors, but I've adapted them for patients, and I've really have given this all over the country at this point. Um, so my let me just get my screen all situated here. Okay, so my goal here today is to so first of all, here's what my financial disclosures, which I don't think is really that applicable for today's talk. But really my objectives for tonight is I'm going to talk about sexual orientation, gender identity, and really like the difference between sexual orientation and gender identity, and talk about LGBTQ plus terms. Then I'm going to describe the health disparities that LGBTQ plus people face. I'm going to talk about gender-affirming hormone therapy and how it affects people with MS, and then talk a little bit about some disease-modifying therapies. So it's kind of like an alphabet soup these days, right? With the LGBTQIA plus terminology. You know, several years ago, people talked about using LGBT as the main terms. Then we added the Q. Then we added the plus, which I actually think the plus is the most important term here, which I'll talk about in a second. And some people use IA or IA plus to be more inclusive. So let me just go through some of these terms and tell you about why I think plus is the most important one. So L stands for lesbian, which is similar to the G in the sense that it's someone who is sexually or emotionally attracted to someone of the same gender. So L being a woman, but some women prefer the term gay. And then G, gay, is it's men who are sexually or emotionally attracted to other men, but it could be really anybody that's referred to attraction to the same sex or gender. Now, the B is bisexual, which is someone who's sexually or emotionally attracted to both men and women or to more than one gender identity. Now, what's important here with all these, the LG and B, is to notice how it says sexually attracted and or emotionally attracted to both men and women or men or women for the L and the G. So it allows different and I'll talk about this in another slide. There is a spectrum, right? And this sort of alludes to that. Now, the T, transgender, is interesting because this isn't a sexual orientation. This is a gender identity, right? It's someone whose gender identity or expression differs from what is expected based on the sex they were assigned at birth. Some people say male or female, depending on what they're, if they've transitioned or not. But what's nice about the T is that it's a big spectrum of people. And it's highly individualized to the individual. Now, the Q is a really important term. It means queer or questioning. So queer is just a broad term for anyone who is not straight or cisgender. So sometimes, especially in this talk, you'll hear me just say like queer people, right? That means it's a shorter way of saying LGBTQ plus. Questioning is sort of a newer term that we're using. It's someone who's questioning their sexual orientation or their gender identity. So they're not really sure how to identify themselves presently. And so we include those in the community. Now, the I and the A are interesting because these aren't as common as the LGBT terms. So intersex is really someone who has the biological traits, such as genetic, hormonal, or anatomical differences that really don't fit into a binary male or female category. A stands for a couple of things. It stands for asexual, aromantic, or agender. So asexual individuals are someone who just really don't experience like either little or any sexual attraction to other people. Aromantic is similar in the sense that it's little or no romantic attraction to others. Then agender individuals are someone who do not have a gender or do not have a strong connection to any particular gender. And like I said earlier, the plus I think is the most important term because this just really includes everybody, right? So the plus means that there's unlimited sexual orientations and gender identities, right? It's a huge continuum. So I'm going to talk a little bit about this continuum in a few minutes, but first I want to talk about prevalence. So according to the Williams Institute, about 4.5% of the US population identify as LGBT, which is about 11 million people. 58% are female, 42% are male. And the transgender represents about 0.58% of the US population, which is over 1 million people, actually. Now on this slide, you'll notice this is now this is actually a Gallup poll that was conducted in 2022, which shows Americans in the US who self-identify as LGBTQ plus, and this differentiates them. This is percentages by generation. So you'll obviously see that there's an uptick in people identifying as LGBTQ plus based on the generation. And you'll see here earlier on is the silent generation, baby boomers, Gen X, millennials, and Gen Z. And so there's a couple of interpretations I have of this. So one thing I need to note about this is that they include, versus my previous slide, the Q. So the Q mean questioning. So all of these categories include questioning people who aren't sure of their sexual orientation or gender identity. So obviously younger people are going to be more questioning than older people because, you know, they're just not comfortable yet with, and they're still exploring their sexuality or gender identity. So that's a big important distinction here. Because at first glance, we might say, oh my gosh, there's more people in more recent times that are upticking. And you may be thinking, oh my gosh, there's like an epidemic of queer people happening, right? No, that's not true. So I think the questioning people is a component so that, you know, you see more questioning people in the younger generations. Secondly, I think is an important distinction here is that the silent generation, especially the silent generation and baby boomers, there's a huge amount of shame in this population for being queer. And there's a lot of suppressed people that will basically you know, do anything not to be gay or lesbian, right? And so you see a lot of these people here, they're married in a heterosexual relationship, and then they come out later in life. So that's an important distinction that I see here. So this is interesting stuff. This is an interesting poll. Now it is a Gallup poll, so obviously there's some biases involved in this research, but I think it's interesting stuff. So I alluded to earlier, I talked about gender identity and sexual orientation. So gender identity, basically, it's your inner self of your own gender, and it may not match your sex assigned at birth. Whereas sexual orientation is related to the gender or genders of your romantic and sexual partners. So basically, everybody has a gender identity and a sexual orientation. This is not unique to queer people. Heterosexual, cisgender people, that is their sexual orientation and gender identity. One important distinction is transgender is not a sexual orientation, right? So gender identity is separate from sexual orientation, right? So a transgender person is someone whose gender identity does not correspond to their sex assigned at birth, and a cisgender person is someone whose gender identity does correspond to their sex assigned at birth. And gender expression, which everybody has, is the way a person communicates their gender to those around them, like their appearance or their mannerisms. So here's the slide I was talking about earlier about this sort of spectrum. So people have developed this gender bear diagram, which is like, you know, it's like this teddy bear that has all these signs here. So the expression is the whole thing, right? So your gender expression, you have your biological sex, you have your orientation, which is your sexual orientation, and then your gender identity is in your brain. So the gender identity could be binary, it could be a woman or a man, or it could be a spectrum in the middle, right? So this alludes to what I was saying about the plus being the most important thing, is that there's unlimited gender identities and sexual orientations. Same thing with sexual orientation, right? So it could be binary, a woman or a man, or it could be somewhere in the middle, or it could be no one, like in the case of the asexual people. Sex assigned at birth, it's really three things. It's either female, male, or intersex. Obviously, intersex is a spectrum in and of itself. And then the gender expression, right? How you express yourself to others. You can be feminine, you can be masculine, or you can be somewhere in the middle. So this is a really beautiful way of looking at this, is that it is a spectrum, no matter what we think. And there really is unlimited sexual orientations and gender identities. And therefore, for the trans people, gender affirmation is a process where a transgender person is able to outwardly express who they are to others. And there's many different types of gender affirmation. There's social, legal, medical, and surgical affirmation. So social affirmation is just changing your names, pronouns, clothes, hair. It's really like more of a social thing, right? And then legal affirmation, which is obviously it's dependent on the state, unfortunately, here in the US, is changing your name and gender in official documents. Now, medical affirmation is really just basically gender affirming hormone therapy, which is using hormone replacement therapy to sort of align one's body to their gender identity. And then surgical affirmation is actually using surgery to change one's anatomy. And what's nice about this is that it's highly customizable to the individual, right? So not everybody will go through all 4 steps. Some people will just go through 1 step. And so it's just highly customizable. Okay, so I'm going to shift gears a little bit and talk about health disparities amongst queer people. So queer people as a minority group, we do face a lot of health disparities. We have higher rates of disability, higher rates of physical limitations, overall poor general health. Now, we do see higher rates of HIV amongst gay and bisexual men and transgender women. However, that is changing these days, right? So the incidence of HIV is actually going down amongst gay people. Mostly because of the development of PrEP therapy. So actually the highest prevalence is amongst gay, bisexual men and transgender women, but the incidence, which is new cases, we're seeing higher rates amongst heterosexual people these days. We see higher rates of overweight and obesity in lesbian and bisexual women, high rates of cancer, overall cancer rates, higher rates of cardiovascular disease, and overall higher rates of healthcare utilization, which is a marker of the poor general health. So why is this? So I have 2 theories on this that I talk about. One is adverse childhood experiences, which you see higher rates amongst LGBTQ plus people. And also something called minority stress theory, which I'll talk about, which is basically exposure to anti-LGBTQ plus discrimination, which leads to adverse health outcomes, okay? Now, a lot of this has been studied in other minority groups, but it is applicable to us as well. So the ACE study, or Average Childhood Experience Study, was a study that was conducted in the 90s through the CDC and Kaiser Permanente. Kaiser Permanente, if you don't know, was a big healthcare system out in California. It's expanded to other states now, but back in the 90s, it was in California. So they enrolled over 17,000 people, and they looked at those surveys asking questions about their childhood experiences. So it was given to adults, and then they looked at their current health status of behaviors. But they theorized that the ACEs were either harms that affect children either directly, like abuse and neglect, or indirectly through their living environments. So what they found is that childhood trauma was very common, and this is not unique to LGBT people. This was just overall in the general population for those 17,000 people. So 2/3 of that cohort had an ACE score of at least 1, and 87% of those had more than 1, right? So people usually experience more than one type of trauma. And they found a direct link between childhood trauma and the adult onset of chronic disease, as well as mental health problems. And more types of trauma, like a higher ACE score, increases the risk of health, social, and emotional problems. So they've studied this with MS patients, actually. So there was one study that looked at the ACE scores with MS patients, and they found a higher ACE score led to poor health-related quality of life and increased emotional distress in patients with MS at the time of diagnosis and 1-year follow-up. And there was increased anxiety at the 1-year follow-up, which tells to me that these patients had less resilience because of their childhood trauma. But going back to LGBTQ plus people, so overall, this is the rates of the ACE scores amongst queer people. So the average ACE scores for a gay or lesbian person was 2.19. So that means over more than 2 childhood traumas. Bisexual people had the most at 3.14. And here's a comparison to other groups. So straight people had 1.6. White people had 1.52, Black people 1.69, and Hispanics were 1.80, which I think is really interesting. Okay, so let's shift gears a little bit. So I'm going to talk about discrimination now. This is minority stress theory, which has been studied extensively in multiple minority groups, and LGBTQ plus people are a minority group. So basically, tons of studies have showed that LGBTQ plus discrimination leads to adverse health outcomes. What's interesting about this is that it could be interpersonal discrimination, like bullying, but it also could be structural discrimination, such as laws or policies. What's also really interesting about this is that it's linked to health harms, even for those who are not directly exposed. So just hearing about or witnessing someone being discriminated against, or even hearing in the news about laws or policies, causes internalized stigma, low self-esteem, expectation of rejection, and fear of discrimination, right? This fear of discrimination is something that's very insidious to these people. And like I said, it can happen indirectly. So even people coming from like really supportive homes, just hearing exposure to other people causes minority stress. Okay, intersecting identities like gender, race, or socioeconomic status may exacerbate the harms. So the more minority groups someone's in, the higher rates of health harms there are. So for example, a poor Black trans woman, that's multiple minority groups. That's a very concerning group of people that we really worry about, who have a lot of health problems. Anyway, protective factors, this is called social support theory, is protective against minority stress theory. So things that are protective against minority stress are peer, community, and familial support, obviously. But, I talk about this with other healthcare professionals, is that actually affirming healthcare and social services and inclusive healthcare practices actually helps the patients. And it's not like you need to be like someone who's providing hormone replacement therapy. Just having a affirming healthcare system actually helps protect against minority stress. So it's something really important that I advocate for with healthcare professionals. Okay, so let's talk about MS patients, with queer MS patients. So there's not been many studies on the queer MS experience. I have them all listed here, so let's go through them. So LGBTQ plus patients were more likely to change MS centers in this one study, okay? When it says OR equals 2, that means they were twice as likely to change the MS center in this study. That OR means odds ratio. Now, LGBTQ plus MS patients also had a lower involvement in LGBTQ plus activities due to their MS status. What that means is that once diagnosed with MS, queer people withdrew from their queer communities. Also, vice versa, queer MS patients were less likely to have involvement in MS activities. So that's why it's really important to have MS support groups that are LGBTQ plus focused. Now in NARCOMS is a big registry run through the Cleveland Clinic that looks at patient-reported outcomes with MS. So according to that database, it's a big database, about 0.45% of the database were trans and 4.6% were non-heterosexual, which is similar to that second slide that presented about the overall prevalence. They did find similar healthcare utilization between LGBTQ plus people and heterosexuals. Trans people had less comfort discussing sexual health, which I think is, a little obvious. And bisexual people had the lowest satisfaction with their care. Okay. So I think it's just interesting stuff, right? So, there's not been, this is it. This is what's been studied with the queer MS experience, right? We don't have any studies about looking at health outcomes with MS. Okay, so I'm gonna shift gears again. I'll talk about gender-affirming hormone therapy in people with MS. All that really gender-affirming hormone therapy is that you're using hormone replacement therapy to sort of align one's body with your gender. And there's two types of gender-affirming hormone therapy. There's feminizing gender-affirming hormone therapy and also masculizing gender-affirming hormone therapy. So we'll start with feminizing gender-affirming hormone therapy, which is really meant to have development of female secondary sex characteristics using estrogens and progestins replacement. You also want to add a second medicine which will suppress male secondary sex characteristics, which is using like spironolactone and finasteride. Those are the medicines that are usually used for anti-androgens. So there's not been like really much studies like really any studies looking at the trans experience with MS. So I kind of pull from like, at least for estrogen therapy, looking at perimenopausal women. So overall, we see worsening of disability for MS patients during menopause in women. Therefore, estrogen replacement after surgical menopause has shown beneficial effects, for example, on memory. We also see higher physical quality of life measures in postmenopausal women on hormone therapy, right? So estrogen replacement therapy, although it does have side effects, we do see higher physical quality of life measures on postmenopausal women who are on hormone replacement. And then they've looked at this in animals. So they found, so EAE is the animal model of MS. It stands for experimental autoimmune encephalomyelitis. It's used in mouse. They do it in mice. So they found that there's actually estrogen receptors on immune cells, and they found that there's neuroprotective effects of estrogen replacement in the EAE model of MS. There are some trials ongoing looking at estrogen replacement in MS patients. This is not specific to trans people. So there's a phase 2 trial, which is more of a safety trial. They looked at giving estrogen replacement plus Copaxone or glutathione acetate versus placebo. It met its primary endpoint of reducing relapse rates. And there's an ongoing phase 3 trial looking at estrogen replacement plus a variety of disease-modifying therapies versus placebo, with the primary endpoint of looking at cognition or memory problems, measuring with the PASAT test. So this is an ongoing trial that's going on. So hopefully that'll come out soon. Now, masculizing gender-affirming hormone therapy is really easy because you just use testosterone. And that basically allows development of male secondary sex characteristics and suppression of female secondary sex characteristics. Now, testosterone in MS has been really studied a lot. So there are neuroprotective effects in MS patients. So it does cross the blood-brain barrier, testosterone. It protects spinal cord neurons from oxidative stress and increases something called neurotrophic factors, which help protect against damage in the central nervous system, and also decreases microglial activation in the animal model of MS. Microglia are the immune cells that are in the brain, okay? And then low testosterone levels has been shown to be a risk factor for MS in males. And basically, they found that low testosterone levels throughout the lifespan is a risk factor for MS. They found so low prenatal testosterone in men have shown to go on to develop MS compared to controls. In puberty, we see higher rates of MS in obese males because there's higher rates of androgens to estrogens with obese males. And then in adults, multiple trials have shown that lower levels of testosterone in patients with MS in males compared to controls. It's been across the board. Okay, my computer's freezing. Okay, so some trials on testosterone. So there was a study that looked at improvement in cognition and slowing of brain atrophy using testosterone replacement. Low testosterone levels has been associated with increased disability scores. That's what the EDSS means, and worsening cognitive decline. Now, this is an interesting point, number 3. This is specific to trans people. So they found a possible association between the male to female transition and development of MS. So basically in this trial, they looked at, it was a record linkage trial. Basically what that means is, I think it was in the UK, basically they looked at the co-occurrence on insurance claims between MS, and then they also looked at the diagnosis code of gender dysmorphia, meaning like there's a problem with your gender. And they found that there are higher rates of MS in this cohort versus what they thought was to be expected. So there were only 4 cases that they found of MS co-occurring with gender dysmorphia, versus there's only supposed to be 0.6 patients. So therefore the relative risk was 6-fold. So I have a couple of comments about this. So one is that the only 4 cases out of several thousand patients that they found, I think that's actually pretty good. And the funny thing is about this, well, not funny, but serious thing, is that so gender affirmation is actually a medically necessary thing that needs to occur for trans patients. So there's really, really high rates of suicide amongst non-transitioned trans people who like aren't able to transition. So it's absolutely a life-saving, medically necessary thing that happens. And I think most trans people will take a small risk of getting MS over not transitioning, right? So I sort of have that issue with this trial, their conclusions about it. It's just that it still needs to happen. But it's interesting stuff. So the idea is that there was testosterone suppression, and therefore it led to MS. That's what their theory was. But it's just one study. I think more studies need to be conducted. Now, there's an ongoing phase 2 trial, which is a safety trial looking at testosterone supplementation, looking at a remyelinating effect, which would be great, and also neuroprotection in MS. And they're looking at MRI parameters as the primary outcome. So cool stuff. So I'm just going to touch a little bit on disease-modifying therapy selection, and I'm going to go open it up to questions. So really the point about this is that one is that not enough research is being done. So a lot of this has to do with HIV patients specifically. So what started me on this path was that I was having conversations with other neurologists, and they were like having this impression that patients who were diagnosed with MS who also had HIV, that they should only offer certain disease-modifying therapies to them, and those happen to be lower efficacy therapies. And I had an issue with that because why are we excluding the high efficacy therapies from these patients out of fear of the HIV getting worse? And I think what led me to that question, I did a lot of self-reflection, is that I think there's different types of HIV patients, right? So there's a patient who's had HIV for many years, they're undetectable on antiretroviral therapy, normal lymphocytes, normal CD4 count. That's very different than a patient who was recently diagnosed with a high viral load. It's very different. And the problem is that most clinical trials just flat out exclude patients who are HIV positive. It's not about the viral level. It's about if they're just ever tested for HIV positive, if they've ever tested positive for HIV. I have an issue with that with the pharmaceutical companies because I think we're excluding a lot of patients from these trials, and therefore it has this downstream effect on the labeling of the FDA approval process, right? So when you don't study a patient group, you can't say that it works in that group. So a lot of these disease-modifying therapies have exclusions if you're HIV positive. Not only that, but right now in the clinical trials, and I do the clinical trials, there's no collection about sexual orientations. There's no collection about gender identity, right? And when we create a new patient in the portal for the clinical trials, it literally just says male, female. There's no other option. So I think in order to define if there is a difference with the MS experience amongst queer people, we need to collect the data. And I think we're not doing that right now. There's been a shift in recent years to sort of increase representation of minority groups in clinical trials. Right now, it's really the focus has been racial and ethnic groups, but I think we need to do a little bit better and really hone deep on one, socioeconomic classes, and then two, sexual orientation and gender identity. I think those are really uncollected. But let me talk a little bit about the disease-modifying therapies labeling. So first of all, oral cladribine, which is called Mavenclad, they actually have in the label that says contraindicated for use with patients who are HIV positive. It doesn't say anything about the viral load. It just says if they're HIV positive. There's also a warning about simultaneous use with antiviral and antiretroviral drugs. So the problem with this is that these drugs might interfere with the activation of cladribine. But the nice thing about cladribine is that it's out of your system so quickly. So I think like as long as you pause the antiretroviral drugs, you'll be okay. But you know, there is a warning. I mean, it just says contraindicated for use with patients who are HIV positive. Now, alemtuzumab, which is Lemtrada, it also says the same thing, contraindicated for use with patients who are HIV positive. Now, I do agree with them on this one because there is prolonged reduction in the CD4 positive lymphocyte count. So, I mean, it does last a while. So the reduction in the CD4 count. So I see the issue with that, but I don't really see the issue with cladribine. Anyway. Now, ocrelizumab, Ocrevus, ofatumumab, Kesimpta, and now ublituximab, Briumvi. There's a warning for use in patients with, quote, an active infection, whatever that means, right? So there's arguments for HIV being, it is active, right? I mean, like, you're never cured of HIV. However, some people say, including myself, it's turned into a chronic infection. It's probably still active, though. So again, the issue is that most clinical trials include these patients who are HIV positive. And therefore, when you ask the question to the pharmaceutical companies, what's the data on these? They say they don't have any data. So we just don't know. So it's up to people to try it out in clinical practice. And we may be, it may be the blind leading the blind a little bit. But this is a problem. And the problem is that, in 2023, pretty much all the clinical trials for the BTK inhibitors, they're also excluding patients who are HIV positive. So this isn't an old issue. It's still ongoing. So it's not like it's been fixed. So anyway, I'm going to open up to question and answers in a moment. But in summary, while you guys are reflecting on questions, is that what I hope I've taught tonight is that queer people are at higher risk for certain health conditions due to health disparities. And it talks about minority stress theory and the adverse childhood experience study. Gender-affirming hormone therapy, I do think, has benefits in patients with MS, although there is a possible link for development of MS in males undergoing gender-affirming hormone therapy. A little more research needs to be done. Certain disease-modifying therapies should be used in caution with people who are HIV positive, unfortunately, although clinical trials really must aim to improve inclusivity for these patients. So without further ado, I think we have some questions coming in.
Yes, thank you so much, Dr. Conte, for a wonderful presentation and coming back and bringing us some updates. We will now take some questions. Just a reminder to please be sure to type in your questions. We did have a few come in prior to tonight's webinar, and we'll dive right into this one. So this is around stigma and health disparities for the LGBTQ plus and MS community. So patient surveys show that often members of the LGBTQ plus community receive poor quality of care due to stigma and sensitivity and lack of awareness. And I know you touched on that during your presentation. So how could individuals living with MS who are part of the sexual and gender minority community self-advocate to overcome systemic barriers?
I mean, it's really hard because, like, well, on the one hand, self-advocacy is just super important for everybody, right? We need to be advocates for ourselves, especially as patients in the healthcare system, because we all have implicit biases, right? As a patient, I have implicit biases. As a doctor, I have implicit biases, and so we really should self-advocate for ourselves no matter what. You shouldn't be passive about things, but it's really hard because it's like I struggle as a queer person because, like, self-advocating for, it's like, why do I need to self-advocate for myself? Especially with like, LGBTQ plus health issues, right? It gets frustrating, right? And that kind of goes to show that, like, here's the problem is that there's a lot of I'm gonna speak as a healthcare professional now. There's a lot of healthcare professionals that sort of lack awareness of these issues, right? And it's not that they're doing something wrong, it's just that they're just not aware. They just don't know what they don't know. And my experience as a patient in the healthcare system is that, at least by me, I live up in Illinois. So it's a pretty opening environment here in the Chicago area. At least I think so. I can't speak for everybody, but at least my doctors, they've been like open to having discussions about sort of queer issues, but I don't know if that's for everybody, right? So some people, some doctors are like, well, why is this important as a neurologist, for example? Well, like I said earlier in the presentation, with social support theory, we as healthcare professionals have an opportunity to sort of protect against minority stress for these patients by creating an inclusive environment. So I'm answering this in a roundabout way because there's just not one way to do this. I mean, I think you need to sort of select your healthcare professionals in a safe way. And unfortunately, there's not a great way of doing that except for trial and error. I think most queer people will easily realize pretty quickly if they're not in a safe situation with a healthcare professional. But I think I want to defend my colleagues. I do think most of us as health professionals are pretty willing to, especially the younger generation, to be open about these things.
Yeah. And then the individuals also have the option, if they're not comfortable in having, these discussions with their healthcare provider, they can always go somewhere else.
Yeah, I mean, that's the
If
thing.
yeah, so if there's someone else that, could be a better fit. So you're not necessarily stuck, for some individuals who may think that they're stuck with perhaps
But I
one
do want
healthcare
to
provider.
say, like, it can be exhausting, right? To have
Yeah.
to, like, change and try. It's like, I wish there's this one way of like a database of like, this is the people you need to go to, but it just doesn't exist. And
Yeah.
it can be exhausting. And I want to recognize that and acknowledge that.
Yeah. Yeah. No, absolutely. Absolutely. So now, what advice would you offer to someone who feel nervous and anxious about having conversations with their healthcare provider?
Well, I think you need to be comfortable with your healthcare professional first, right? So, like, maybe you don't need to disclose on the first visit, although I would encourage you to. So, what's interesting is that some of the data, especially for trans people, actually, like, trans people delay their healthcare due to fear of disclosure, right? So they will not go to the hospital as quickly. They will not go to preventative care as quickly because they're fearful of disclosing that they're transgender to their health professional. Not only that, if they do enter the healthcare system, they usually don't disclose right away, which is important to know for as health professionals, because we need to know if you're on like hormone replacement therapy, things like that. So it's a huge issue, that there's this fear of the healthcare system. I think because of historically, the healthcare system hasn't been very kind to these people. So I think, what was the question again? What advice do I have for
Yeah. So yeah, no, that's
someone
fine.
navigating
Yeah.
the healthcare system?
Yeah. So like, what advice do you have for having, conversations with their healthcare provider?
Well, I think you should just be direct. I mean, that's what I do with my doctors. Like, I'm just direct about it. It's like, look, I'm a gay man. This is my health history. And I disclose. I mean, I'm not fearful of it. I think it's also location dependent, unfortunately. Like I said, I'm in the Chicago area, which, I think one, there's many doctors in the area if I need to change, but two, I think
That's
everybody's
true.
pretty open here. The issue is, like, if you're in some of the states or in the rural areas, you might not be in a comfortable situation. My advice is really just, I think you should be direct. I don't think you should be shy. um and I think you'll realize quickly, almost like a test, if you will, of the
Hmm.
doctor or healthcare
Yeah.
professional, like if they're going to be a good fit for you.
Yeah. Yeah. No, that's true. I mean, you can definitely tell from your first, conversation that you have with your provider if this is someone that, you feel you can move forward with, and having like a patient doctor relationship or not.
Mhm.
No, this is wonderful. So now, microaggressions. I know you touched on that as well during your presentation. So microaggressions could be manifest in a healthcare setting. So what impact do microaggressions have on the LGBTQ plus community?
Yeah, I think microaggressions are really sneaky. So if you don't know what microaggressions are, they're sort of these, like, how do I explain it? It's like these, like, sort of implicit,
Hmm.
like, it's like when an implicit bias becomes explicit. Like when like, for example, like, you know, I'll use since we're talking about trans people a lot. When let's say a trans person says, this is my the way you want me to be addressed, but then the doctor doesn't change like the way they address the patient. That's the microaggression. Or microaggression, it's like you disclose that you're gay, and then like the doctor doesn't like look you in the eye anymore or something like that. Those are like microaggressions, right? Those are just some examples. It could be a lot more sneaky though. Um, so how do you deal with them is obviously, I think, acknowledging them and also self-examining why it's affecting you. And I think just being open about them too. I think calling out the microaggressions is really important too. One problem is, one thing I lecture about to doctors on this topic is that you always want to, I tell doctors you want to approach these patients with an air of curiosity, but you don't want to be voyeuristic. If it just, does that make sense, right? So you want to ask questions, but you don't want to, keep asking when the patient's becoming uncomfortable or when a boundary's been set. And so I sort of talk to doctors about that, is that there's a fine line between curiosity and voyeurism. And obviously you don't want to cross that line. Well, the line can be very blurry. Does that make sense?
That makes complete sense. No, thank you. So we're going to switch gears a little bit and we're going to talk about hormone replacement therapy and MS. What is the relationship between hormone replacement therapy and MS symptoms?
Right. So, I think a lot of the patients, and this is for cisgendered people, is that we see a lot of problems like memory, fatigue, and just poor overall quality of life with low hormone levels. And we see with both testosterone and estrogen. And so with estrogen, we obviously see with postmenopausal women, have more memory problems. And then when we replace them with estrogen, we see improvement in the symptoms. Same thing with testosterone, right? So people feel a little weaker with low testosterone levels, and then when you replace it, they might feel a little more energy.
Okay. Why has my testosterone, okay, so hormone replacement therapy, made my symptoms almost non-existent?
Yeah, so it's funny because I think so it's a really complicated topic, and I'm not an endocrinologist, so I don't know if I have the best answer to why this is, but it is a hormone that's important, right? And it's a complex thing, right? So why does testosterone go into the brain? Like, that's weird to me, a little bit. And it's it crosses the blood-brain barrier. It causes problems with like everything. And so this is a common thing I hear, is that when people go on replacement. Now the problem is replacement comes with its own risk. These are not risk-free medications, but patients do feel better. Now, it's whether it has a disease modifying effect, I'm not so sure, meaning I'm not sure if it affects the course of MS, but it certainly helps with the symptoms.
Okay. So now for someone who is transgender, what are some of the challenges that they may experience?
Right. So, I think transgender people, it's just sort of a misunderstanding of transgender people overall these days. Remember, transgender people are just people, right? And I think, it's obviously, you just have to put yourself in their shoes, right? Just imagining being in a body that doesn't match your internal gender, right? And, having body parts that aren't what that belong to you. Just imagine being in those shoes. And I just think we should approach these people with empathy. First and foremost is just understanding their perspective. The advice I would give people who are transgender is, obviously you want to make sure you're in an affirming healthcare environment first and foremost, because like I said, the patients that aren't able to transition have very high rates of suicide. And that's just it's a very concerning group of people.
Yeah, yeah. Now, someone did ask prior to the webinar, how do you find a doctor who will treat a trans person with dignity? And I think we touched a little bit on that earlier.
Yeah, it's just like with non-trans people who are queer. You have to, there's a difference. So I talk to doctors about this subject a lot, and especially neurologists. So I did this presentation at the American Academy of Neurology this year, and a couple of people came up to me. It's like, well, why is this important to us? We're not the ones performing gender-affirming hormone therapy. We're not doing surgery. We're not, practicing it. And I think we have an opportunity, though, and this is what I tell them we have an opportunity for the inclusive care to help support them. And, it's hard to find these people, right? So as I said earlier, trans people have they delay their care due to fear of rejection. And there's not a great way of doing this. Now, I'm working with this student right now, this med student who got an MBA, and she's doing this. She's trying to create a directory of inclusive practices. So I'm hoping that gets kicked off. She's trying to do this is like it's practices across the specialties that provide inclusivity. So that's not live
Wonderful.
yet, but I'm hoping for that. Now, there's this one company, well, organization, the Gay and Lesbian Medical Association, or GLAMA. They have a directory, but yeah, I think you have to pay to get in the directory. So there's obviously some biases there. But I think it's mostly people who are like providing HIV care, for example. And
Okay.
then WPATH is another resource. WPATH is an organization that provides standards of care for trans people. It's a group of people who have come together and said, this is the standards of care for treating trans people. And they have a directory but this is people who are actually providing like gender affirmation services.
Okay.
So it's hard.
Yeah. Yeah. Now, someone was asking about detransitioning. So what about someone who is detransitioning? What would that affect the MS treatment?
Yeah, so one thing about detransitioning, so people like, at least in the media, are like, oh my gosh, people transitioning, like what they're gonna regret their choice and stuff. Well, the nice thing about transitioning is that it's so customizable that there is a process for detransitioning. This is rare that this happens, that some people down the line sort of like change their mind, or maybe they just didn't realize that they were fitting into this binary group. Maybe they're more of a gender fluid person. And so this is where most people who transition are very happy with what happened. Anyway, the detransitioning process, I actually think it's fine with MS. Obviously, there might be some hormonal changes which could play a role in some of the symptoms of MS, but I think it's fine. I think it's just you have to watch these patients a little more closely, but I think people do pretty well.
Okay. So we'll talk a little bit about HIV and MS. And again, I know you touched on that a bit. So is there a direct correlation between MS and HIV?
Not really. I don't think so. I mean, there's been some theories that having HIV, which creates an immunosuppressed environment, might actually protect against MS, or even that maybe you shouldn't treat people with HIV who have MS. I actually disagree with that second statement because we sometimes see patients who have MS contract HIV. So there's two questions here. Is one, is an existing HIV patient less susceptible for developing MS? And then the second question is someone who has MS who develops HIV, are they more like less at risk for relapses? And I just think we just don't know for sure. But HIV does create an immunosuppressed environment. But the thing is once you treat HIV, you sort of that gets normalized. So I think these patients definitely so I don't think there's a direct correlation. I think it may be some sort of indirect thing that might happen. But it obviously complicates things a little bit.
Okay. On the topic of HIV and MS, is it true that DMTs could increase the risk of AIDS?
So AIDS being the sort of like the final stage of HIV, I don't think so I mentioned earlier the DMT is like we just don't know for sure how the interaction with HIV and the DMTs work because they're just not being studied, unfortunately. I don't think if we're talking about HIV, I don't think they increase your susceptibility to getting HIV. However, if you're certain disease modifying therapy, certainly would lower the CD4 counts or the lymphocyte counts, which could then, I guess make someone more at risk for AIDS, which would be a complication from HIV. But I think as long as you treat the HIV, I don't think it's a problem.
Okay. So let's talk a little bit about research. So where could research information be found? And how do we know about research and clinical trials specific to people living with MS? So we can start with the first part of that question. Where could research information be found?
Well, if we're talking about LGBTQ plus people, One great resource is the Williams Institute, and I think that's through UCLA is where that's housed. It's just this database. It's a really nice website where it kind of stores all the research studies on LGBTQ plus people, or at least the more important studies. And so I drew a lot of stuff from the Williams Institute. There's also the What We Know project. I think that one's through Cornell, if I'm correct. So correct me if I'm wrong if I'm not. That one also houses a lot of research. So I think the Williams Institute is mostly like statistics, epidemiology stuff, whereas like the What We Know project is more about like the health disparities. So if anybody's interested in like going through a rabbit hole, go check out those websites. What was the second question?
And then the second part is, how do we know about research and clinical trials specific to people living with MS? So would perhaps their providers have that information apart from the sites that you've mentioned?
Yeah, it's really tough because like some of the healthcare professionals just don't keep up with that stuff. I'm really interested in that, so I definitely keep up with it. But it's so hard. There's so much research going on in the MS world right now. Really, I actually learned statistics a few years ago that MS outside of cancer is it's actually the #1 most researched disease state. And I think the asterisk with that, the footnote is that they separated the cancers out. It wasn't just cancer as a whole, which would obviously be #1. It was like the little like breast cancer and like colon
Okay,
cancer, but it actually surpasses those disease states, the MS research. So it's just so much research going on. I think you just have to you really need to rely on, unfortunately, well, fortunately and unfortunately, some of the foundations. The problem, why I said it unfortunately, is that then it sort of gets filtered, if you will.
okay,
The information, it gets filtered through somebody who's doing that, which is good because then you can get the most important stuff. But who defines what's important and what's not important? Does that make sense? That's
right,
why I say unfortunately,
yeah,
is who's defining that. Um, and so it's really hard. I mean, if you really want to go to the raw data, I would go to the clinicaltrials.gov website. That
okay,
houses all clinical trials that are done, at least. Though this is not just all research, this is just clinical trials for drugs. But they have the old trials up there and the results from them. But that's a lot. That's an advanced way of looking at it.
okay, that's very helpful. So let's talk about mental health. So there is some research evidence on the prevalence of mental health disorders in the community in terms of minority stress, which you touched on as well. So what strategies could they use to cope with a chronic disease and stigma?
So one thing before I answer this question, I want to emphasize is that the research shows that LGBTQ plus people face more mental health problems, but it's not because we are just crazy, right? It's because we face minority stress, we face adverse childhood experiences that increase our risk of having mental health problems. That's one important distinction I want to make. So it's just some of the statistics that come out make it sound like it's just we have higher rates of mental health problems because we're
Mhm.
gay. That's not true. It's because of our experience.
Right.
And then, so how to combat that, I think is really looking at support, social support. And, you need to create a village around you, even with non-queer people with MS, right? You need the support of the community. You need familial support, hopefully. You need friendships. I think the support groups are really important because I mentioned like queer focused support groups because I mentioned earlier that queer people were more likely to withdraw from queer people with MS were likely to withdraw from the queer community, the local queer community when they were diagnosed with MS, and also vice versa. They don't participate in MS activities when being clear. So it's really important to have MS focused LGBTQ plus groups. There's not many, not that there needs to be right now. National MS Society has a virtual one I know of. That's really good. And the MS Foundation just created sort of I don't know how to describe it. It's a Facebook group and there's like a working group that they have. So that's really nice if you can check that out.
Okay, okay. No, thank you. Those are very helpful. One question that came in earlier today, so said, identity issues. I was a true femme, but since MS, I feel my identity slipping towards left of center and now not sure anymore. Please help a damsel in distress.
Well, I mean, I think this person is really like, I mean, that kind of goes to the point of that, having MS is an identity crisis, right? I mean, this isn't unique to queer people, right? I think people who develop MS, they look at their lives with a different lens. After there's pre-diagnosis and post-diagnosis. I think most patients can commiserate with that. And it does create an identity crisis. I mean, for this person, I would definitely suggest some online resources looking at the gender bear, for example.
Mhm.
And there may not be a quick answer to this. It may take some introspection over time, some support from good healthcare professionals, maybe some therapists who provide gender affirmation. Those are good resources for this person.
Wonderful, wonderful. Well, you know what? We are already at the top of the hour.
Look
Um,
at that.
I know it just went by so fast, as always. So thank you so much, Dr. Conte, for providing us with such informative, information about how MS affects people from the LGBTQ plus community. This has been an amazing and insightful program. So thank you so much once again. This concludes our webcast. Tonight's webinar was recorded and will be made available on our website. Please visit MSAA's calendar of events for our upcoming webinars and events. On behalf of MSAA, we would like to thank you once again, Dr. Conte, for taking the time and providing us with the tools needed to better understand the impact of an MS diagnosis within the LGBTQ plus community. And to our wonderful audience, we would like to take time to thank you for joining us this evening. Please take a few minutes to complete the brief survey, which will appear on your screen momentarily, and know that we are thinking of the entire MS community and hope that you and your families continue to stay safe. Thank you and have a good night.
Thanks, everybody.